thinking about as well. I hopefully do know a little bit more than the average everyday citizen. So bear with me on this. If you ask questions and I don't know the answers, I will tell you I don't really know all the depth of that. So anyway, what most people call today TMJ actually refers to the temporal mandibular joints. And that got to be the expression where people would say, oh, I have TMJ. Well, actually, all of us have two TMJs. And I brought along, appropriate for this season, my little friend, Mr. Spooky. Can you see him?
Uh-huh.
Okay. Now, Mr. Spooky has two TMJs, just like we do. And that is part of our lower jaw, our mandible. And it is this back part of the bone right here on both sides. Okay. And these bones rest up into our skull, right into this area. And they fit right up in here like this. These joints are what allow our mandible, our lower jaw, to open and close. Okay. Now we say this is the most complicated joint in the human body because this joint not only hinges, but it also slides when it moves. I'm sorry, I'm trying to look at the camera. So it has a sliding motion also. And the fact
Okay,
that
we're all moving our jaw as you describe it. It's kind of fun to watch.
Thank you. Yeah, you can help with the chiropractor part of this too. So, and the other part that makes it complicated is that it's one bone with two joints that have to work in harmony when we open and close our jaw. I disconnected the little hinges, and so it's not working as well because I don't play with Mr. Spooky that often. And so we've got two joints that have to work in harmony with each other and at the same time. And it's the only joint in the human body that has what we call a hard stop. And the hard stop happens to be the teeth, the bite. Okay. So most of our other joints, like our hands, they flop around, or our knees. But with our mandible, when we bite together, that's our hard stop. Now, what makes it complicated along with that is in between these two bony surfaces, we actually, and maybe, I don't know if that diagram shows well enough. Oops, where did I go? Okay. All right. So in between these two bony surfaces, we actually have, let's see if I can do this, a cartilaginous disc, which is this part right here. And that floats along with the lower bone. Oh, I'm backwards here and I can't figure it out. Right there. Okay. So when we have this hinging and sliding movement, that disc has to flow along with that and be in harmony. And we also have muscles and ligaments that are all associated with the movement of the joint. So when people say they're suffering from TMJ, what they're usually suffering from is a list of potential symptoms. This is my poor attempt at audio or at visual here. I'm trying to find my camera on my laptop. That's not working. Okay. And that can include things like headaches, jaw joint pain, jaw joint noise or clicking, limited mouth opening, ear congestion, dizziness, ringing in the ears, difficulty swallowing, loose teeth, clenching or grinding, just, vague facial pain, sensitive teeth, chewing difficulties, neck pain, postural problems, tingling of the fingertips, sensitive teeth, and even things like nervousness or insomnia. all of those can be symptoms of what we call, that we use the term for now, temporomandibular joint dysfunction. So instead of TMJ, we call it TMD. And we, from a neuromuscular dentistry point of view, we feel when there is the potential that this hard stop, the bite, can throw the relationship of the joints off, which can affect the ligaments and the muscles, and even just the positioning of the joint. And it can be a contributing factor to some of these symptoms. One of the reasons why we get the association with the ear function is that the joint can actually be pushed towards the back of the joint, which actually affects the ear canal. And that can be a problem with causing the congestion or the ringing in the ears.
Mm-hmm.
What can happen is with time, our bite changes. And there can be other causes as well as that. And some of this can be related to just wearing of the teeth. Mr. Spooky here has worn his teeth down quite a bit. And I don't know if you can see how much there. It's kind of creepy, but I'll try not to show too much of that. And by wearing down this hard stop, it will tend to push the upper part of the jaw up and back. We also can have a situation where just the jaw bone itself gets torqued. And so then we get muscles and ligaments on one side being stressed or traumatized more than the other. These muscles then can lead to problems like headaches and that sort of thing, or the nondescript facial pain. We also believe that the head is just the top part of the spinal column. And so we're well aware that the whole relationship of the lower body can be connected to all of this as well too. So we talk about problems being either ascending or descending. So it may start with the bite and it can descend down the body, can lead to problems with neck pain and that sort of thing. We can have problems with the knees or the ankles or the hips being out of whack, and it can show up as far as symptoms in the mouth. So that's kind of just a nutshell of TMD. And along with the positioning of the jaw, that can relate to what we call obstructive sleep apnea, or OSA it's called. And so one of the things that tends to happen is our jaw naturally wants to go in a position that we say is down and forward from the jaw, from the joint, and in relationship to the bite, so to speak. And as I was saying, there can be various things that can happen through life that can inadvertently cause the jaw to go back and up instead, which can often lead to problems. We also know that when we say down, we mean that there needs to be a certain openness to the bite, especially in relationship to the back teeth. And if someone has worn their teeth down through grinding, what we call bruxism, that in and of itself can cause a lessening of what we call the vertical dimension or the opening of the bite, and cause what we call, or lead to what we call, an overclosure. This can also happen with the loss of teeth, missing teeth, and teeth tend to drift or shift, and it will change the vertical dimension. Sometimes even with orthodontics in the past, especially, it was often recommended to extract first bicuspids to solve crowding situations. And we do feel that that in and of itself tends to shrink the size of the arches and can also lead to changes as far as the dimension, the vertical dimension of the teeth as well too. So what happens with obstructive sleep apnea is that we get a lessening or reduction of the airways. And this can be analyzed by what we call cone beams. And those are just 3-dimensional images that will actually measure the dimensions of the airway. And so this is showing your airway down, from the top part of okay, these are your teeth right here. And then this is showing the airway from the back of your mouth down into your throat. And that's looking at it from the side. And this is looking at it more from a frontal view. And this was the pictures over here were done before treatment, and these were done after treatment. And you can see that there's a change, that the red area is the airway, and that's gotten larger, which allows for more air volume. So sleep apnea has historically been treated by, the physicians tend to recommend treatment with what we call CPAP. And this is a situation where they're actually forcing air into the airway to create an increased amount of air volume. From a dental point of view, what we tend to do historically is do what we call a mandibular advancement appliance. And this is an appliance that is made to keep the mandible from falling backwards in the throat. And so this picture shows how when you're sleeping, if your airway is, where am I? More open on this picture, but if the airway is open towards the back, but if the mandible falls back, the tongue tends to fall back, and it can close off the volume of the air in the mouth as well as shutting it down in the throat. By pulling the mandible forward and keeping it in a forward position, then that keeps that airway open. This is an example of a mandibular advancement appliance where there's an upper and lower component to it, and they're hinged together, so keeping the mandible in a more forward position. That also doesn't really treat the cause of the problem, but it does treat the symptoms, same as this CPAP does. By trying, it's somewhat more treating the cause in that they're actually trying to open the airway as opposed to just forcing air into the airway. A newer line of thought also that I've worked with is dealing with what we call a is looking at the upper airway. And the upper airway is more the upper sinuses, which are not just in the positioning of the mandible down here, but we're looking at the upper sinuses in this area. And we know that the floor, or that the palate, the roof of the mouth, is, and the shape of that has an impact on the the airway in here. And the floor of the mouth is the bottom of the sinuses there. And in some people, that the palate can be, I think I was saying the floor of the mouth, but I meant the palate, not the floor of the mouth. The palate can be high and narrow, and that can impinge upon this airway. And when that happens, then we also can have a lessening in the air volume. And there is an appliance that we have now that is called a DNA appliance. And that is an appliance that is worn on the upper palate. It's a removable appliance, and it's used to change a shape. If you can see it, this palette is the start, and you can see how narrow and triangle shaped that is, and how high and narrow. And after wearing the appliance, it becomes more rounded and wide, and it's more horseshoe shaped instead of triangular shaped. And the palate actually becomes more flattened, and all of that helps to improve the air volume. And so that in and of itself is actually treating more of the cause than the symptoms. So does anybody have any questions?
I do.
Okay.
So basically, this is sort of like a brace, but from interior to extend the jaw, extending the area so that more air can inflow. What is the
DNA appliance is actually considered to be an orthodontic appliance, but it's what we call a palatal expander. So it's really working on remodeling the bone itself. It's not so much moving teeth as it's remodeling the bone.
Okay.
So for a long time in dentistry, we've done palatal expansion for very small or very young children. And it was what they called rapid palatal expansion. The doctor that did the research and developed the DNA appliance actually figured out that palatal expansion could be done in adults, which it was never thought that could happen. But he's done the extensive research, and of course, lots of usage of the appliance now has shown that. So did that answer your question?
Yeah, part of it. So what would be the guesstimated time in general to expand the palate?
Well, it depends, of course, on the individual situation.
Right.
And I would say that most of the time it's months, not years.
Like 3 to 9 months, depending on the individual situation.
Right.
Okay.
And it's a removable appliance, and typically it's worn about 16 hours out of the day. So, which means that, if you had a job, which most of us don't have anymore, where you had to be in the public eye 8 hours of the day, you wouldn't actually have to have it in your mouth. Aesthetically, it's not that bad. It does have a a wire that goes across the front of the upper teeth, kind of like retainers, you know, if anybody's had an orthodontic retainer like that. And it does cover the biting surfaces of the teeth. So, you know, trying to speak with it, it takes a little adjustment, but that sort of thing. But it's really meant to be worn kind of, you know, late afternoon, evening, nighttime, that type of thing. So there's a lot of hours in the day where it doesn't even have to be in the mouth.
I have more questions, but maybe other members have other questions. I don't want to just take up her time. If not, I can. Mark, any question? Can I continue, or some other members may have questions?
Sure, I'll have one. Well, the TMD device, or the TMD, do you find people are using that as a first form of treatment now, as opposed to drugs and other forms of therapy that have been used in the past?
Okay, so when we're treating specifically just for TMD, and I didn't even talk about this, but initially what we do is we make what we call an orthotic. And that, there's a picture of that. Okay. And so typically when I do that, it's a clear removable appliance that fits over the biting surface of the lower teeth. And we use that as a phase 1 treatment to actually help with diagnosis. If we can eliminate or significantly reduce the symptoms, that's telling us that there is a dental component to it. Okay. That appliance is typically worn 24/7 under ideal circumstances. So, and part of that is because muscles do have memory to them. If you're taking the appliance in and out of the mouth, the muscles are never going to figure out how, what the natural new positioning is and how to relax and become symptom free. If we do get success with that, then the ideal situation is that we want to change the dental structures so that they meet this new, what we call neuromuscular bite. And that can either typically be done through orthodontics by moving the teeth, or in some cases, we do it with restorations in the mouth, which usually means crowns to change the bite.
Interesting. Okay. Anybody else have questions before John goes again? Nope. Go ahead, John.
Okay, so Dr. Jean, so would you recommend a senior, she's supposedly to wear sleep apnea, but she is not willing to do it. So doing this palate thing, will it help? Do you recommend or not recommend, or any of feedback or advice about a senior who is 80 years old to do this thing to enhance the capacity of the inflow air, or no comment?
Well, I can't comment specifically without knowing the whole situation with the particular individual, but I don't think that there's an age limitation on it if the appliance is appropriate. Does that make sense?
Yeah. What would be the guesstimated cost in general about this service?
Well, it's going to run several $1,000s.
Okay.
So
Okay.
between
to
5,000 and 10,000, put it that way.
Is it
5,000 to 10,000.
any
Okay.
of it covered by insurance?
Well, if it's billed as an orthodontic appliance, and if there's the dental benefits plan covers orthodontics, there would be some orthodontic benefits. There's also some potential if there's a sleep study done and the patient's diagnosed with the sleep apnea, that there might be some medical benefits as well too.
Okay. Thank you. Any other questions? Well, thank you, Jeannie. That was very informative.